Daniel, just doing another test from the room. Can you hear us? And can we hear you?
Yes, we can hear you in the WebEx. Can you guys hear us in the room?
Testing from the WebEx to the room. 1, 2, 3, 4, 5. April, if you could hear us, please let us know. Again, everyone on WebEx, thanks so much for your patience. We're just trying to get the room tied in to WebEx.
Testing again from the room. Can you hear us? And can we hear you if someone could speak for us?
Hey, April, yes, we can hear you in the WebEx. Can you guys hear us in the room?
We still can't hear you. Give us one more minute.
again to everyone on the WebEx. We continue to apologize. We're just trying to get the room tied in. They can't hear us at all. So, Past Recording Studio and the Cisco engineers are on it. As soon as we have word, we'll get started. Thanks for your patience again.
Good morning, Mr. Brindisi. Can we get a 5 count from you real quick, please?
Just an update that we can now hear you in the room, Daniel. The audio is just low for the controller, so if I could get the audio a little louder, I think we can begin the hearing shortly. Can I get another test from WebEx, please?
Yes. This is a test from WebEx to the room. 1, 2, 3, 4, 5.
Thank you. Just 1 second, please.
Okay.
Mr. Brindisi, can we do one final 5 count from you, please?
Five, four, three, two, one.
Thank you very much, sir.
Can I get another audio test from WebEx, please? This is April in the room.
The test from WebEx. 5, 4, 3, 2, 1.
Thank you. Can I get another test from WebEx, please, of audio volume?
Another test from WebEx. 5, 4, 3, 2, 1.
Thank you.
Madam Chair, are you ready to begin?
Yes.
Please begin with a 5 count.
I'm sorry, I'm having trouble hearing you.
Please begin with a 5 count.
5, 4, 3, 2, 1. Good morning. I call this hearing to order. A quorum is present. Without objection, the chair is authorized to declare a recess at any time. We have a number of members and witnesses participating remotely today. Before we proceed, I would like to go over some items for those participating remotely. First, if you are experiencing connectivity issues, please make sure you or your staff contact our designated technical support so those issues can be resolved immediately. Members participating remotely must continue to use the video function for the duration of their participation in the hearing unless they experience connectivity issues or other technical problems that render them unable to fully participate on camera. It is committee policy that members participating remotely will remain muted when not recognized, just like turning your microphone on and off during an in-person hearing. This is out of courtesy to all members on the committee and so that background noise does not interfere with another member who is recognized to speak. When you are recognized, you will need to unmute your microphone and pause for a couple of seconds before speaking so that we will be able to hear everything you say and so that it will be captured on the live stream of this hearing. If you wish to be recognized, please raise your hand using the WebEx raise hand function, unmute your microphone, and ask to be recognized. If you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteransaffairs.hearing@mail.house.gov. It will be uploaded to the committee document repository. Please keep in mind that you will need to refresh the repository page as it does not automatically update. Without objection, members will be recognized in order of committee seniority for questioning witnesses today. This will make it easier for me to ensure all members participating have an opportunity to be recognized. Does any member have a question about the conduct of this hearing with members participating remotely? Seeing none, before we proceed to the substance of today's hearing, I'd like to ask unanimous consent for our colleagues, Representatives Neal, Kennedy, Gottheimer, and Houlihan to participate in today's hearing, should they all be able to attend. Without objection, so ordered. Also with us today are our full committee chairman, Mark Takano, and ranking member Phil Rowe. Thank you both for joining us here today. And I now recognize myself for an opening statement. Today, the subcommittee will examine the quality of care and infection control practices at state veteran homes during the COVID-19 pandemic. We will also consider whether there are opportunities for VA to improve its oversight of state veterans' homes and how construction, renovation, and other physical plant improvements may help state veteran homes better prepare for future public health emergencies. Since the start of the pandemic, at least 40,000 residents of long-term care facilities nationwide have died of COVID-19, accounting for an estimated 40% of all coronavirus deaths in the United States. Unfortunately, we do not know how many of these deaths have occurred at state veterans' homes or the extent to which these residents are reflected in the 40,000. That's because not all state veteran homes are required to report COVID-19 infection and mortality data to the CDC or to the VA. For the last 3 months, community nursing homes that participate in Medicare and Medicaid have been required to report such information to the CDC, but not all state veteran homes are subject to this requirement. In addition, not all state veteran homes have proactively shared this information with their local VA medical center, so that the department also lacks a complete picture. What we do know right now is that the experience of residents and staff at many of the 157 state-owned and operated veteran homes nationwide has been starkly different from that of veterans and staff in the 134 community living centers, or CLCs, that VA owns and operates. State veteran homes are the largest provider of institutional long-term care for veterans, serving more than half of the approximately 39,000 veterans that receive VA-funded nursing home care last year. CLCs serve about a quarter of the remaining veterans, and VA purchases care at community nursing homes for the rest. I'd like to take a few moments to describe some heartbreaking examples of the human tragedy that has played out at state veteran homes during the COVID-19 pandemic. At the Holyoke Soldiers' Home in Massachusetts, at least 158 residents of the 278-bed facility, 57%, have tested positive for the disease. So far, 76 residents have died, and at least 83 staff members have tested positive for COVID-19. According to an independent investigation published in late June, a series of utterly baffling management and leadership failures, coupled with a severe staffing shortage, delays in testing, delays in closing common spaces, and failure to stop rotation of staff among units contributed to the rapid spread of COVID-19 throughout the facility. As you will hear from one of our witnesses, Paul Barbani, the Holyoke Soldiers' Home has been waiting for years for the state to help fund a renovation project that could have helped the facility better separate COVID positive and COVID negative patients when the virus arrived. The New Jersey Veterans Home at Paramus has experienced a similarly high infection rate among its residents. As of July 22nd, 199 residents of the 336-bed facility, or 59%, had tested positive for COVID-19, and 81 had died. There have also been 93 cases among staff, including 1 death. Employees of the facility say that administrators initially told them not to wear masks, gowns, or gloves because, quote, it would scare the residents, unquote. They also said the facility did not provide pre-pandemic training on proper donning and doffing of PPE and other infection control procedures. Finally, 42 resident deaths have so far been attributed to COVID-19 at the Southeastern Veterans Center, a 238-bed state veterans home in Pennsylvania. There is concern that the home initially lacked access to COVID-19 testing because after 2 or more residents in a given unit tested positive, the facility treated all residents of the unit as presumed positives without testing the rest. According to the Washington Post, this meant that for more than 2 weeks in April, about 30 residents, many of whom had not been tested and had underlying heart conditions, were administered the hydrochloroquine, which is known to cause serious heart irregularities. The FDA emergency use authorization that was in effect at the time stressed that the drug should only be administered to COVID-positive patients in hospital settings, not in nursing homes. The Southeastern Veterans Center lacked the equipment that would have been necessary to provide the FDA-recommended heart monitoring. Now, let's examine the experience of VA's CLCs, which have fared considerably better than all 3 of the state veteran homes I just described. Secretary Wilkie stated in an interview last week that just 2 of the 7,500 veteran residents of VA's CLCs are currently positive for COVID-19. This is a truly remarkable accomplishment. However, as we will discuss during today's hearing, CLCs, which are often located within VA hospitals, have been better staffed than state veteran homes, have had better access to testing and personal protective equipment, or PPE, and have had greater access to in-house expertise on infection control. It should therefore be no surprise that infection rates have been lower within the CLCs than in state veteran homes. However, there should not be 2 different standards of care for veterans residing in CLCs and veterans residing in state veteran homes. We have a moral and ethical obligation to ensure that residents of state veteran homes are afforded similar access to safe, high-quality care and protections during the pandemic. I look forward to discussing what actions VA has taken to help state veteran homes be better prepared to battle this pandemic and the public health emergencies of the future. We cannot allow this disparity in care to continue. Finally, I would like to close by saying that we understand that not all state veteran homes have experienced COVID-19 outbreaks like those I just described. Administrators and staff at most state veteran homes have worked tirelessly to keep veterans safe, and for that we are thankful. In my home state of California, we are fortunate to have Dr. Vito, I never can say his name, Imbasciani, Dr. Vito Imbasciani, at the California Department of Veteran Affairs, or CalVet, and our 8 state veteran homes have so far experienced very few cases of COVID-19. As was recently reported by the Los Angeles Times, a month before COVID-19 was declared a global pandemic, back in mid-February, Dr. Imbasciani and his team began implementing a 38-step plan to keep COVID-19 out of California's state veteran homes. Directors of each home updated their emergency operations plans and stocked up on PPE. There was regular communication between state leaders and administrators of the state veterans' homes, and it seems to have made a real difference. I applaud their diligence and hope that we can help identify and spread these best practices to other homes. That concludes my opening comment, and I will now recognize Ranking Member Dunn to deliver any opening remarks he may have. Dr. Dunn?
Thank you, Madam Chair. The subject of today's hearing, the oversight of the state veteran homes, could not be more timely or more important. Due to their multiple inherent risk factors such as age, health, and the difficulty of physically distancing in a group setting, nursing home residents are particularly vulnerable to COVID-19. The tens of thousands of veterans residing in state veteran homes are inevitably at special risk compared to most of society. In fact, one of the earliest outbreaks of COVID-19 in this country occurred in a state veteran home in Washington State. Since then, there have been several other outbreaks at state veteran homes across the country, and many of the veterans who died in those outbreaks were members of the greatest generation. All of them were heroes. I know I speak for my fellow committee members in offering my prayers and condolences to their loved ones today. Also in my prayers are the staff of the state veterans homes and the VA staff who've been working hard the last several months to contain outbreaks and to provide revised training to improve our national response to this novel pandemic. In addition to keeping our veterans residents safe, you have improved health care throughout America, and I thank you for that. I look forward to hearing more about those efforts today and how this committee can support those efforts moving forward. I strongly suspect that success in containing this virus and future viruses is highly dependent on a more robust and innovative approach to testing. And by that I mean testing both for the presence of the virus and for individual immunity to the virus, whether that be antibodies or T cells. The title of this hearing poses an important question. Who is in charge? The answer should be fairly obvious. These are state veteran nursing homes. As their name suggests, they are clearly run by the states. And it's ultimately the states, not the VA, who is responsible for the day-to-day management and oversight. The ongoing construction, maintenance, renovations, and per diem for these facilities is directly dependent on meeting certain quality criteria. And there are at least annual inspections of every one of these facilities by the VA. That said, the VA undoubtedly has a special relationship with the state veterans' homes. And given the unique circumstances of the COVID-19 pandemic, I think it now is a good time for us to reevaluate that relationship to make sure that it remains healthy, strong, and best structured to support the veterans and their families who depend on state veterans' homes. I appreciate all of our witnesses for being here to weigh in on this subject today, and I look forward to this conversation. With that, Madam Chair, I yield back.
Thank you, Dr. Dunn.
I do, Chairwoman Brownlee, and thank you so much for holding this hearing on this very important topic. And I'm glad that several of our off-committee colleagues are able to join us today to help us address some of the heartbreaking tragedies that have occurred at state veterans' homes in or near their districts. I also look forward to hearing the testimony of our witnesses, so I'll keep these remarks brief. Since the news of the COVID-19 infections and deaths at the Holyoke Soldiers' Home broke in early April, I have been thinking a lot about veterans who reside in these and other institutional settings of long-term care. Clearly, we have not done enough as a nation to ensure nursing homes were ready for this pandemic. Long-standing staffing shortages, inadequate funding, and outdated physical infrastructure have contributed to the rapid spread of this virus in these facilities and state veterans' homes, unfortunately, and they've not been immune to these challenges, and state veterans' homes have not been immune to these challenges. Further, the pandemic has exposed the critical importance of strong oversight and ongoing monitoring of the quality of care and patient safety at nursing homes. It is frustrating that VA has been slow to address recommendations GAO made more than a year ago, and I'm told that there has even been some resistance on the part of the department to implementing GAO's recommendations. Now, as it stands now, I have to wonder how many lives could have been saved at state veterans' homes during this pandemic if there had been stronger, more consistent oversight on the part of VA. Soon after becoming chairman of the Committee on Veterans Affairs, I traveled to Orlando and visited the VA Medical Center in Lake Nona. While there, I toured the CLC and was truly impressed by what I saw. It was better than most any private facility I have visited at home in California, and much nicer than the nursing homes where members of my own family have resided at the end of their lives. I want to understand how we can help state veterans' homes establish similar environments of care. Improving the quality of care and the quality of life at state veterans' homes will require significant investments, to be sure. Currently, more than half of veterans who receive VA-funded nursing homes, VA-funded nursing home care reside in state veterans' homes. But those facilities receive only about 22% of VA's overall budget for institutional long-term care. And in addition, VA's per diems cover only about a third of the total cost of providing care to residents in state veterans' homes. One thing that's become very clear from this pandemic is that it's time to reimagine long-term care in the United States. As veterans age, approximately 80% will develop the need for long-term services and supports. I hope today's hearing will help focus and strengthen the committee's efforts to improve VA oversight and address how we care for our most vulnerable veterans. Thank you, and I yield back, Madam Chair.
Thank you, Chairman Takano, and I'll turn now to Ranking Member Rowe. Dr. Rowe, you're recognized for opening remarks. Thank you, Dr. Rowe. And with that, I'd now like to ask unanimous consent to recognize our colleague, Representative Neal, who will introduce his constituent and the first witness on today's panel, Mr. Paul Barabani of the Holyoke Soldiers Home Coalition. Mr. Barabani is joining us remotely. Representative Neal.
Thank you, Chairwoman Braunley and Ranking Member Dunn. I want to acknowledge your invite today to address the Subcommittee on Health's hearing, Who's in Charge?, examining oversight of state veterans' homes during the COVID-19 pandemic. I'm pleased to introduce your first witness, Paul Barabani, who served as the superintendent of the Holyoke Soldiers Home in my constituency from 2011 to 2016. I've known the Barabani family for a long time. In 2016, Mr. Barabani resigned his position because he felt the state was not addressing critical needs at the home, like inadequate staffing and crucial physical renovations. He and other former employees recently formed the Holyoke Soldiers Home Coalition to fight for state-level reforms and to be a voice for the home's veterans and their families, as well as the facility's employees. He has been an undaunted advocate for the Holyoke Soldiers Home. In March, COVID-19 hit the Soldiers Home particularly hard. It was one of the first state veterans homes to experience a major outbreak. Insufficient staffing and infection control issues resulted in the deaths of 76 veterans. I am a regular visitor to the Holyoke Soldiers Home, having an uncle there and many friends. In April, the National Guard stepped in to provide extra staffing and other critical details to help stabilize the situation and create a safer environment. The shocking outcome led to an independent investigation into the tragedy. Like Mr. Barabani, I welcomed the report of the Massachusetts Governor Baker's administration, which was released in June, that pointed to a clear need for more transparency and, indeed, accountability. But more detailed reforms are needed. First, the facility needs to maintain the current number of beds and oppose attempts to downsize. Second, a new adult daycare facility should be established on site. And finally, Western Massachusetts needs to have a voice in the discussion about the future of the facility going forward. These conversations cannot occur just in Boston. On a number of occasions, I have used directed spending from Washington to assist the physical plant at the Soldiers' Home. Always happy to assist. While I wholeheartedly embrace plans to renovate the Soldiers' Home, it needs to be treated with the same equity as its counterpart in Chelsea, Massachusetts. This is a seismic chore, but I am willing to help provide federal resources so the state can move forward to rebuild the facilities and create a more transparent, healthy environment for our veterans and those who care for them. Last week, after my many conversations with the administration about securing resources for nursing homes and state veterans homes, the Department of Health and Human Services announced it would devote $5 billion of CARES Act funding to long-term care facilities and state veterans homes. I have been in contact and brought the Holyoke Soldiers Home and challenges specifically in conversations with Secretary Azar. The problems revealed as the COVID struck the Soldiers' Home were not unique to veterans facilities in our nation. I have long been concerned about the health and safety of millions of Americans who receive care in nursing facilities, and understanding that more than 60% of the deaths in Massachusetts have occurred in nursing home facilities. We have worked tirelessly to get the administration to address the gaps in oversight and shore up consumer protections, both prior to and during the pandemic. The death toll in nursing homes during the COVID-19 pandemic has brought to light many challenges that patients and their families have been facing for years. Last month, I encouraged the Ways and Means Health Subcommittee to hold a hearing on this important issue, and I was struck by the heart-wrenching testimony of the witnesses. Across the country, staff continue to report that they need more access to personal protective equipment, and there have even been reports that PPE sent to nursing homes from the federal government might be inadequate to the task. What's happening in nursing homes across the country right now is not a coincidence. It's an out and long-standing deregulation campaign that has been waged against nursing homes for years. Their policies have exacerbated the already present safety threats to these residents and the thousands who have died because of it. We need to understand more needs to be done to contain the virus, to protect these patients and workers, and keeping the administration on keel for that is essential. I have repeatedly raised these concerns, again with Secretary Azar, Administrator Verma, and some of the recent actions that they have taken to address nursing home issues flow from my public and private suggestions to them on this matter. I'm pleased that they're starting to listen to us, and the urgency of the Holyoke Soldiers Home is but one example of the work that needs to be done. There is much more, however, for all of us to follow through on. The HEROES Act, which the House passed over 2 months ago, includes provisions to provide vital resources to nursing homes and strengthen protections for patients and workers. Advocates and health professionals alike agree that the inaction earlier this year has worsened the outcomes and fatality rates in nursing homes, which are now estimated, as Chairwoman Braunley noted, to be at least responsible for up to 40% of the deaths nationwide. I'm delighted to introduce Mr. Barabani today to share his insights on this tragedy, and just as important, what steps can be taken to ensure this doesn't happen again. With that, I yield back the balance of my time.
Thank you, Mr. Neal, and I now introduce the remaining witnesses on this morning's panel. We also have Ms. Sharon Silas, a director from U.S. Government Accountability Office Healthcare Team. She is joining us remotely. Next, here in the hearing room, we have Ms. Melissa Jackson, who was recently named President of the National Association of State Veteran Homes. And finally, we have 4 officials from the U.S. Department of Veteran Affairs. Dr. Teresa Boyd is the Assistant Undersecretary for Health for Clinical Services at the Veterans Health Administration. Appearing with her here in the hearing room is Dr. Beth Taylor, Assistant Undersecretary for Health for Patient Care Services, and they are accompanied from afar by Dr. Scotty Hartreft, the Executive Director of VHA's Office of Geriatrics and Extended Care, and Mr. Ryan Lilly, the Director of the VA New England Healthcare System Envision 1. We will now hear from the prepared statements from our witnesses. For those participating remotely, I will remind you once again to please pause for 2 or 3 seconds before speaking so that the recording will capture all of your words, and please remember to do so when answering members' questions as well. So thank you. Your written statements in full will be included in the hearing record without objection. And Mr. Barabani, you are recognized now for 5 minutes.
Thank you, Chairman Brownlee, Ranking Member Dr. Dunn, members of the subcommittee. Thank you for this opportunity to represent the Holyoke Soldiers Home Coalition at today's hearing. Our mission is to advocate for the staff and residents.
Mr. Barabani, not to interrupt you here, but we can't hear you very well, so I don't know whether you're speaking loudly enough or whether it's a technical problem. Can you start from the beginning, speaking louder, and see if that works?
Certainly will.
Thank you.
Chairman Brownlee, Ranking Member Dr. Dunn, members of the subcommittee, thank you for this opportunity to represent the Holyoke Soldiers Home Coalition at today's hearing. Our mission is to advocate for the staff and residents of the Soldiers Home in Holyoke by demanding improved staffing, the construction of a new home to include an adult day health care program, and better governance and oversight. The lack of state support for the Soldiers Home in Holyoke has been a long topic of much consternation among veterans in Western Massachusetts. We greatly appreciate the commitment of Congressman Richard Neal for his support of the construction of the new home to include the adult day health care program. A decade ago, in 2010, the annual VA survey noted life safety and resident room size.
Mr. Barabani, I again apologize. We're having some difficulties here in the hearing room. So subject to the call of the chair, the subcommittee is recessed, and we will try to fix this issue.
A good rehearsal.
To everyone on WebEx, again, we apologize. We're having some trouble hearing all of us on WebEx inside of the hearing room in the Capitol. We're working on it right now, and we'll let everyone know when we can resume. Feel free to stay at your seats or turn your cameras off, whatever you're most comfortable with. We'll let you know when we solve it. Again, we certainly do apologize.
Team, we got a bad echo in the room. I think it's with the two codecs, maybe.
This is Matt in HVAC control. I've muted the two codecs. Please let me know when I should unmute one of them to avoid the echo. To everyone on the WebEx or on any of the staff Zooms, again, we're experiencing some technical difficulties with everyone hearing WebEx inside of the room. Please stand by and we'll have this resolved as soon as we can. Thanks so much for everyone's patience.
Daniel, can you hear me on the platform? 1, 2, 3, 4, 5, 6.
HRC control, I've bumped off COD1 and I've unmuted COD3.
Doug, max out the VTC slider. Okay, Matt or Daniel, give me a 5 count, please.
Hi, it's Matt on the WebEx. 5 count test. 1, 2, 3, 4, 5.
Okay, much improved. Thank you.
I would like to call this hearing back to order, and we're going to take it from the top. Mr. Barabani, you are now recognized for 5 minutes. Thank you for your patience.
Thank you for this opportunity to represent the Holyoke Soldiers Home Coalition at today's hearing. Our mission is to advocate for the staff and residents of the Soldiers Home in Holyoke by demanding improved staffing, the construction of a new home to include an adult day healthcare program, and better governance and oversight. The lack of state support for the Soldiers Home in Holyoke has long been a topic of much consternation among veterans in Western Massachusetts. We greatly appreciate the commitment of Congressman Richard Neal and his support for the construction of a new home to include the adult day healthcare program. A decade ago, in 2010, the annual VA survey noted life safety and resident room size deficiencies at the home, which was built in 1952. Of the 278 beds in 2010, less than 5% met the VA standards. During my tenure, we created a new design to accommodate 270 residents with construction of a new wing containing 120 private rooms, and renovation of the existing building into private or semi-private rooms configured into neighborhoods typical of the VA's community living center model. The plan was approved for the VA construction grant program in 2013, and in 2014, the VA approved the design of an adult day healthcare program at Holyoke. It is the coalition's belief that the lack of sufficient staff and overcrowded rooms were root causes of the rapid spread of the virus, resulting in the death of 76 veterans at the home. When asked what he would have liked to have done differently regarding the Soldiers Home, Massachusetts Governor Baker said the Pearlstein report made it clear that his administration's Department of Veterans Services did not properly oversee the superintendent or the long-term care facility. He responded, "That one's on us." The annual VA survey is a thorough review of the clinical life safety standards to ensure quality resident care and compliance with VA standards. The most recent survey, completed on January 31st of this year, stated the facility did not have an established infection control program. My thoughts on improving VA oversight of the veterans home would be a much greater collaboration and partnership between the VA and the veterans homes. Here are my recommendations. That the VA survey should include an analysis of staffing in relation to resident complexity as the critical first step of the annual survey. The VA should require that the facility of jurisdiction to assist the state veteran home with developing corrective action plans, utilizing their expertise and vast network of data. Recall my mention of the January 2020 finding that they lacked an infection control program. Imagine if the facility of jurisdiction and the home had worked collaboratively to implement such a policy in the month of February. The survey process should require the VISN director to approve the home's corrective action plan. I would incorporate the results of the State Veteran Home Survey into the performance metrics for the director of the VA facility of jurisdiction and create a formal partnership between the facility of jurisdiction and the state veteran home, which should include attendance of state home staff at VA training, access to VA online resources, joint participation in disaster preparedness exercises to include pandemic or infectious disease outbreak, assist with the placement of challenging residents that are beyond the home's capability. The facility of jurisdiction could also provide assistance visits, collaboration in behavioral health management, quality management, dietary pharmacy, infection control, the list just goes on. And finally, establish a methodology to formally address recurring deficiencies, especially those that require corrective action above the facility level. Remember the 2010 findings regarding room size and a project that was approved for funding and the adult day? They still remain on the state matching fund list, lacking state matching funds. In 2013 and every year until my retirement in 2016, I needed the VA's help to influence the state decision makers, to provide funds for the proper staffing and the renovation of the home to ensure quality veteran care. I often ask, what if they had listened to my request for additional staff and the creation of individual rooms and the renovation? How many of these deaths may have been prevented if they had listened and acted? The Department of Veteran Affairs and the state home share a sacred and moral obligation to provide for quality care, whether in a community living center or state home. Through a professional partnership and collaboration, we have a unique opportunity to vastly improve the quality of veteran care for future generations, not only in my home state, but throughout our great nation. Thank you. Subject to your questions, this concludes my testimony.
Thank you, Mr. Barbani. I now recognize Ms. Silas for 5 minutes. And again, just remember to pause for a couple of seconds after you unmute.
Thank you. Chairwoman Brownlee, Ranking Member Dunn, Chairman Takano, Ranking Member Rowe, and members of the subcommittee. I am pleased to be here today to discuss our recent work on state veterans homes. My testimony today summarizes findings and recommendations from our 2019 report on VA nursing home care. In that report, we describe VA's utilization and expenditures for nursing home care, the use of inspections to oversee the veterans' quality of care, and the information that VA publicly provides on the quality of care through its website. In our report, we made 3 recommendations that addressed VA's oversight of state veterans homes. One of those recommendations, that VA develop a strategy to ensure regular monitoring of contractor performance, was recently closed. The other 2 recommendations remain open. In our 2019 report, we described 3 types of nursing homes that VA either provides or pays for veterans to receive nursing home care: community living centers, community nursing homes, and state veterans homes. Of these 3 types of nursing home care, state veterans homes are the largest in terms of veteran utilization, providing care to approximately 20,000 veterans a year at a cost of about $1 billion. And while VA does not exercise any supervision or control over the administration, personnel, or maintenance of the homes, VA does conduct annual inspections of all state veterans homes in order to assess compliance with VA quality care standards. In fact, VA is prohibited from making payments to the state veterans homes until it determines that the homes have demonstrated they have met applicable quality standards. Oversight of state veterans homes' quality of care varies based on the source of funding. Specifically at the federal level, if a state veterans home receives Medicaid or Medicare funding, both CMS and VA oversee the quality of care at the home through annual inspections. At the time of our review, 107, or about 2/3 of state veterans homes were inspected by both VA and CMS. The remaining 1/3 of state veterans homes were only overseen at the federal level by VA. And while most state veterans homes are also inspected by the states, not all are. For those that do not have any state oversight and are also not receiving Medicaid and Medicare funding, VA is the only agency that conducts regular inspections of veterans' quality of care at these nursing homes. One example of this case is the Holyoke Soldiers Home in Massachusetts. It is not a state licensed facility, nor is it enrolled as a provider with CMS. VA's oversight and inspections are modeled after the methods used by CMS. And similar to CMS, VA inspections are an important tool in the oversight of nursing home care. In our 2019 report, we found VA State Veterans Homes contractor performed all of the required inspections for the 2018 contract year and identified 192 deficiencies in about half of the state veterans homes. However, we found that VA could strengthen its oversight of state veterans homes' quality of care. First, VA was not requiring its state veterans homes contractor to identify all failures to meet VA quality standards as deficiencies. VA allowed contractors to cite low-level deficiencies. These are deficiencies deemed to have no risk or minimum risk of harm as recommendations. This is contrary to the approach that CMS takes, which requires its inspectors to cite all deficiencies, regardless of the severity level. We also learned that VA permitted its contractors to allow state veterans homes to fix issues while the contractor was on site conducting an inspection, to avoid being cited for a deficiency in their inspection report. For the 2018 contract year, state veterans homes had a low number of deficiency citations, an average of 1 deficiency per inspection, as compared to community living centers, which averaged 4 deficiencies per inspection. VA officials cited the low number of deficiencies for state veterans home, likely a result of VA's collegial approach with state veterans homes and the home's willingness to make on-site corrections. Lastly, VA does not share information on the quality of care at state veterans homes on its website, similar to what is provided on community living centers and community nursing homes. This is problematic because VA's Access to Care website is an important tool for veterans and their families to make informed choices on which facilities in their community the veteran should reside. And as I have previously noted, VA is uniquely positioned to provide this information to the public. The emergence of COVID-19 and the increased risk of our aging veteran population contracting the disease highlights the importance of VA's role in overseeing state veterans homes. With more than half of the 39,000 veterans receiving nursing home care through state veterans homes, it's critical that VA ensure that these facilities are taking the necessary steps to safeguard the health and the well-being of our nation's veterans. This concludes my prepared statement. I'd be happy to answer any questions that you might have. Thank you.
Thank you, Ms. Silas. And Ms. Jackson, you are now recognized for 5 minutes. Welcome.
Chairman Brownlee, Ranking Member Dr. Dunn, and members of the subcommittee. Thank you for inviting the National Association of State Veterans Homes, NASVA, to testify on how state veterans homes have cared for our veterans during the COVID-19 pandemic. I currently serve as president of NASVA, an all-volunteer organization of state home administrators dedicated to enhancing the quality of care and life for our veterans and their families. Since 2011, I have served as the chief executive officer of the Vermont Veterans Home, which has a 130-bed skilled nursing care program and a small domiciliary care program, so I can share my experiences both as a NASVA leader and a state home administrator. Chairman Brownlee, as a condition of federal funding, VA certifies and monitors the care and treatment of veterans in state veterans homes. Although it is true VA does not have a statutory authority over the management of state veterans homes, it has extensive regulations covering every aspect of state veteran home operation. As required by law, state veterans homes are inspected annually to ensure compliance with VA's extensive regulations. This includes more than 200 detailed clinical standards, as well as dozens of fire and life safety clinical standards, as well as a financial audit. When a VA inspection finds deficiencies, state homes are required to resolve or rectify them or face the threat of losing VA per diem support. As the GAO confirmed in July of 2019 report, quote, VA requires state veterans homes to produce corrective action plans and to track the state veterans homes' progress until they are resolved, unquote. Rest assured, NASVA is committed to working with Congress and the VA to ensure that all veterans who choose to reside in state veterans home receive the highest quality of care. Chairman Brownlee, when COVID began to spread, state veterans homes were among the first institutions to take significant precautions to protect our residents. Battling communicable diseases is already a regular part of operations of our homes, and we are required to have strong infection control regimes, which we utilize every year to battle influenza and other viruses. When VA announced it would suspend visitation to its CLCs, state homes had already taken that precaution, and the rest would soon follow. State veterans homes started screening staff and residents for COVID symptoms. However, as we have learned since, the significant level of asymptomatic spread of the virus made it almost impossible to keep the virus out of any facility or location in the country. From the onset of the pandemic, state veterans homes have had difficulty procuring sufficient personal protective equipment due to an inadequate national supply. Testing was and remains another critical challenge, and when a resident or staff test positive, staff are forced to quarantine, thus creating staffing challenges at many homes. It is also important to note that our residents are primarily older men who have significant disabilities and comorbidities. As we have learned, COVID-19 has disproportionately impacted older men with these underlying health conditions. Unlike community homes, which have more women than men, state homes are overwhelmingly male, and about half are of 85 years of age or older, compared to just 1/4 of the veterans in the VLCACs and community nursing homes. Chairwoman Brownlee, we are very grateful to this committee for supporting several provisions of the CARES Act, including temporary waivers from the occupancy rates, emergency construction funding, and new authority to allow VA to provide state homes with PPE. Although VA officials declined to use the new PPE authority for state homes, since late April, VA has provided significant support to dozens of homes providing PPE, testing, clinical staffing, and other support. I have heard from dozens of NASVA members how VA has supported them over the past months. Overall, during this pandemic, VA has been a responsive, supportive partner to veterans' homes. Looking ahead, as the pandemic continues, state veterans' homes still need federal support to help us protect and care for our veteran residents. In order to fully utilize the emergency construction grant funding in the CARES Act, we need the law amended to allow VA to award grants on a rolling basis, allow grants to cover retroactive costs, and to eliminate the matching fund requirement. State homes also need emergency financial relief to help us cover the enormous expenses due to COVID-19 and the tremendous loss of VA per diem support due to the COVID and non-COVID related deaths and the suspension of new admissions. We are asking Congress and the VA to continue to provide the same level of total per diem support to each state veterans home during the pandemic as it was previously provided. Chairwoman Brownlee, this concludes my testimony, and I'd be happy to answer any questions you or other members may have.
Thank you, Ms. Jackson, and I now finally recognize Dr. Boyd, who is our final witness on today's panel, for 5 minutes.
Thank you. Good morning, Madam Chair, Ranking Member Dunn, and distinguished members of the subcommittee. I appreciate this opportunity to discuss the quality of care and infection control practices at state veterans homes during the Corona disease 2019 pandemic. I'm accompanied today by Dr. Beth Taylor, Assistant Undersecretary for Health Patient Care Services, Dr. Scotty Hartranft, Executive Director, Office of Geriatrics and Extended Care, and Mr. Ryan Lilly, Network Director, Vision One. VA takes pride in our provision of world-class health care to America's veterans, as well as the nation during times of crisis like we are experiencing now with this pandemic. VA is uniquely positioned to assist during emergencies due to our presence in communities across the 50 states and U.S. territories. During COVID-19 pandemic, VA has continued to serve veterans, their families, caregivers, and beneficiaries, and has filled a critical role in the nation's response as part of our fourth mission. As background, VA supports the 158 state-operated state veterans homes by ensuring they meet VA standards through audits, reconciliation of records, and annual surveys. After a home has been surveyed, a formal document is prepared and submitted to the State Veterans Home leadership for resolution and corrective action plans for any deficiencies identified. Earlier this year, when COVID-19 was declared a pandemic, we promptly reached out to offer assistance to the state veterans' homes. Even though these homes are state-run facilities, we have always had an open and positive communication with them and maintain a readiness to help should they require aid. We share a common focus and priority: safe and quality care for our veterans. We understand that we must work together, especially during these unprecedented times, as the safety and well-being of the veterans is our primary mission, now and always. VA senior clinical leadership met with the National Association of State Veterans Homes in town hall settings to offer information pertaining to updated guidance for our VA CLCs and sharing lessons learned and ensuring ongoing bidirectional dialogue during the pandemic. In addition, VA Medical Center and VISN leadership actively communicated with their respective state veterans homes, encouraging them to request assistance or further guidance if needed. To date, assistance has been provided both locally by the VA Medical Center of Jurisdiction or the VISN, as well as enterprise-wide deployment of staff and resources. VA has deployed more than 400 personnel in support of state veterans homes and has admitted over 500 veterans from these homes to VA inpatient care. Additionally, the CARES Act that was signed by President Trump in March of this year provided relief of several federal regulations to reduce burden to the state veterans homes and provides aid in the form of personal protective equipment, medications, other various equipment and supplies. State veterans homes' needs are assessed on a case-by-case basis with their respective medical center or VISN. We have also provided support in the form of training for use of personal protective equipment and sharing of infection control practices specific to this COVID pandemic. Likewise, due to the absolute need for restriction of visitors to long-term care facilities and recognizing the need for continued social contact between veterans and family and friends, VA has loaned 92 iPads to 73 individual state veterans homes to help alleviate a bit of the social isolation that will no likely occur. VA has enacted its fourth mission during the COVID-19 pandemic. By practice, this is done to improve the nation's preparedness for response to war, terrorism, national emergencies, and natural disasters by developing plans and taking actions to ensure continued service to veterans, as well as to support national, state, and local emergency management, public health, safety, and homeland security efforts. VA has always worked in collaboration with state veterans homes and continues to make every effort to provide care to our veterans in any and every capacity. This pandemic has been a learning process for our healthcare system, and we intend to use the tools we have acquired in real time to assist others as needed. While the final chapter on lessons learned about COVID has not been written, we have confidence in the strength and agility of the VA system of care. Our system focuses on the healthcare continuum, and it brings together the expertise from research, clinical practice, and administrative services, which positions us to be a helpful partner to the state-run state veterans homes, as well as to the rest of American healthcare. We value the relationship we have with the National Association of State Veterans Homes, and we appreciate the insight of our GAO colleagues. The continued support of this subcommittee is essential to providing high-quality care for our veterans and their families. Madam Chair, this concludes my testimony. My colleagues and I are prepared to answer your questions. Thank you.
Thank you, Dr. Boyd. I will now recognize myself for 5 minutes of questioning. And my first question goes to Dr. Boyd. So, Dr. Boyd, the title of this hearing is Who's in Charge? So where does the buck stop with regards to responsibilities for quality care of our nation's veterans?
So while thank you for that. So while the VA has standards that must be met, especially during the initial certification survey and the annual surveys, truly the operational aspect of that is in the lap of the states. It is a state-run, and we do respect the autonomy of the states and with regards to their operational oversight.
Would you agree that the oversight role that the VA does is critical to maintain high-quality care?
I would say that not only the oversight with our surveys, but also the ongoing communication that we have prior to COVID, and especially during COVID, is a huge part of ensuring good quality care.
Okay, well, from my perspective, and the GAO is here listening, so she can correct me if I'm misstating this, but to me, it seems as though the oversight it's loose oversight on VA, and from my vantage point, in terms of high-quality care for our veterans, it seems the oversight piece and VA's role in the oversight is really the sort of the last safety net to ensure high-quality health care in these state-run facilities. So, let me just describe what I believe to be true. First, the VA hires a contractor to do the inspection. So in most cases, the VA is not doing, they have authority to walk into a facility, but it is a contractor who is actually doing the inspection. But VA does not, or at least in the past, it may be doing it now, but VA does not require that the contractor to identify does not require the contractor to identify failures to meet quality standards as deficiencies, rather as a recommendation. So if there's no deficiencies, it's only when there are deficiencies in the oversight is when that triggers the VA Medical Center then to come in and to review the home's correction plan. So if there's no deficiencies, there's no trigger for the local VA Medical Center to come in and take a look. And then on top of that, the VA is not monitoring the contractor's performance of inspection. So there is no formalized process to evaluate the contractor who's evaluating these state-run homes to ensure quality of care. So in my sense, the oversight piece is extremely important and particularly even more elevated during COVID-19 to ensure high-quality care within the VA. So, and to me, the way the oversight is structured right now, it is loose and should really be, at a minimum, tightened up quite extensively. So, Ms. Ellis, what I just stated, did I make any errors in my statement?
No, Chairwoman Brownlee, you're correct. I would also just add that for a number of state veterans homes, there are a handful that are not inspected by the state. And in those circumstances, and they're not inspected by the state, and they're also not receiving Medicare or Medicaid, so they're not inspected by CMS. And in those circumstances, VA is the only entity that is coming in and providing any oversight of quality of care.
And it's my understanding too, Ms. Ellis, that in some cases it's the same contractor to come into a VA, same contractor that's doing the inspection for the VA as is doing the inspection for CMS if they're, providing Medicare and Medicaid at the facility. Is that correct? Not in every case, but in some cases. You have to unmute.
Sorry. No, that's not correct. It's not the same contractor.
In any circumstance, it's not the same.
Yeah, it's completely a different contractor.
Okay.
With CMS, they are using state surveyors, and with VA, they're using a specific contractor, Accelon.
Okay, but does CMS monitor their contractors in terms of doing, performance evaluations of their inspections?
Yes, they do. They do periodic observational assessments, like like VA is supposed to be doing. They also do what is called a comparative review, where they will come in behind the inspectors, and CMS will conduct their own duplicate inspection to check to see that the inspections were conducted correctly.
Thank you. My time is up. Dr. Dunn, you are now recognized for 5 minutes.
Thank you, Madam Chair. I will try to keep my questions brief. I encourage you to do the same with your answers. Ms. Jackson, would the National Association of State Veterans Homes support or oppose giving the VA more direct managerial authority over the state veterans homes?
Thank you for your question. That's not something we as an organization have discussed. I'd be more than happy to go back and poll my colleagues and do a response for the record.
You've developed a letter on this?
We have not, no.
So you're yes or no?
We, as an organization, I can't speak for the organization. We have not, as an organization, taken a stance, so I would like to go back.
Well, we'd like to, that's sort of what we need to know here, right? Dr. Board, what do you think?
Again, we absolutely respect the autonomy of the state and their operational oversight and responsibilities with these state veterans homes.
That's a good answer. I'm satisfied with that. Dr. Taylor, what do you think are the primary lessons we learned from the outbreak that occurred at Holyoke and the others you've dealt with? Now, this is not going to be a short answer, so I'm going to ask you to get back to my office with that, please, and send us a simple list of corrective actions. You know, something. You know, I'm a doctor. We can understand this. If you'll, what corrective actions do you think we learned from this pandemic? And I won't ask you to answer that essay question here because you couldn't do it in 30 minutes, let alone 5. Dr. Board, you may be responsible for that list as well. I don't know. But I'm going to ask you next. The 500 veterans from the state veterans homes, roughly, who were admitted to VA medical centers with COVID, will they return to those homes or will they be some other part of the system?
So the answer to that is that many times they're veterans or the spouses that actually reside at the state veterans homes, and they come to us into the ICU settings as well as med-surg, and sometimes into our own CLCs. And the disposition of or returning of those veterans and or their spouses is determined by the status of their health once they recover.
So we're being aware of these heart-wrenching dislocations, sometimes involving great distances. That was my concern. Also, Dr. Board, I'm alarmed by the testimony from Mr. Barbaroni that noted that there is no established infection control program in that nursing home. Is that possible? I find it hard to believe. I think every doctor's office has to have one. I can't believe the nursing homes don't.
So I know that you want to keep this short, Dr. Dunn, sir, but I'd like to have Mr. Ryan Lilly respond to that. He's the VISN 1 director, network director, and he knows this case very well.
Make it so.
Thank you.
Thank you. Ms. Silas, we can find Ms. Silas on the WebEx there. How similar are those inspections that the CMS does to the ones the state does? I said CMS, I mean VA, or VA does compared to CMS and the state inspections.
VA models their inspections and their standards on CMS, so they are similar. There are some differences in the sense that CMS is more detailed in terms of their standards. And then there are some differences in terms of the financial and administrative checklists that they use.
Okay, and does
so
that
they are very similar?
does that also apply to the state inspections? You just CMS and VA. How about state?
That if the state's conducting inspections, I don't have that information.
So it does seem like this is a process that could be more or less standardized. I would think. I mean, that's just my thoughts for what it's worth on that subject. Let's see. Dr. Lilly is on the WebEx, I believe. Maybe he could answer the question about the infection control?
Yes, sir. As I understand it, that finding was specific to the domiciliary portion of the home, not the nursing home portion.
Yes.
We'll verify that, though, with your office.
So it was good. Okay, good. Well, then my questions are asked, and you're going to get me an answer on a list. Thanks so much. Appreciate it. I yield back, Madam Chair.
Thank you, Dr. Dunn.
Madam Chair, if I may just, I'm sorry.
Go ahead.
I'd be glad to get that back to you. And also, I wasn't able to chime in. I was hoping that Ms. Silas would have. The recommendation with regards to the oversight and to really monitor the contractor's performance was closed and accepted by the GAO recently. And secondly, the one about reporting deficiencies on the report, that is due in September to be closed out. And so those two things, I just wanted to make sure that you're aware of that.
I am aware. Well, the onus will be on us to make sure that the VA actually complies. So thank you for that. And Chairman Takano, you are recognized for 5 minutes.
Thank you, Chairwoman Brownlee. Dr. Boyd, my first question is for you. In your opening statement, Chairwoman Brownlee, in her opening statement, Chairwoman Brownlee discussed how the committee and the department lack data that would provide a complete picture of how COVID-19 has affected veterans in long-term care settings. We don't truly know how many veterans and employees in state veterans' homes have contracted the disease and how many have died. One thing VA should be able to tell us is how COVID-19 has affected veterans and employees in CLCs. On June 17th, I requested data on CLC bed occupancy rates, the number of veterans and employees that have tested positive, and the number of active cases and the number of deaths. Yesterday, VHA sent us a bit of data on how many CLC residents have been infected to date, and whether they inquired COVID-19, acquired COVID-19 within the VA facility or elsewhere. But we've yet to receive the other data I have asked for. Dr. Boyd, do I have your commitment that the committee will receive these data within the next week?
Absolutely, sir. I'm aware of some of those questions, and we will ensure that we will get that to you as soon as possible. I will be in contact back to you or your staff with regards to an update. Absolutely.
I appreciate Dr. Boyd. And in the meantime, can you tell us about infection and mortality rates among veterans and employees in VA's CLCs?
So we're still learning. We're having lessons learned here. What we have found is that, for the most part, the staff within the world of VA, not the CLCs, but in our VA staff, we have less than 1% of our staff have tested positive. Within the CLC setting, though, which I think is extremely important, and you heard that today, especially from the clinicians and those in the healthcare world, we do know that our communities that are very hot with COVID, it's those staff that live in the communities, just like we all live in a community, and then we go to work and we're asymptomatic. And it's very possible, and what we're finding with our contact tracing is that indeed, for the most part, it is our staff unknowingly bringing that back into these very vulnerable sites.
Well, can you quantify that? Do you have a number? How many of your staff have tested positive at the CLCs?
At the CLCs, I want to get that back to you to make sure that we have the exact numbers, because I know that the staff was working on that.
But what I hear in your voice, the insight you're kind of amazed to share with us, is the fact that so many staff were asymptomatic, and you said unknowingly bringing COVID-19 into these facilities. They contracted, presumably, the virus in the community through community spread. Mm-hmm. Is that what I'm hearing you say?
That's true in healthcare. That's true in society. That is typically where this COVID.
What about you just said, did I hear you wrongly that you were, the testing you were doing it with our CLC employees, that you discovered that CLC employees were bringing, were testing positive because of your extensive testing?
I'll get the numbers back to you, but I can tell you system-wide, asymptomatic staff are the vectors, if you will, of this disease within to our environments.
If you would get us those numbers, I'd appreciate it.
Yes, sir.
I want to better understand how CLCs compare to state veterans' homes, especially those that have experienced major outbreaks, like the ones Ms. Brownlee described earlier in her opening remarks. I mean, it would be helpful to get those actual numbers regarding our CLCs. Ms. Jackson, at the Health Subcommittee Silver Tsunami hearing in March, your organization testified that for fiscal year 2021, VA requested just $90 million for state veterans home construction grants, despite an estimated $1.2 billion worth of pending grant requests. Your association asked Congress to appropriate at least $250 million to fund half of the Priority 1 list, which includes a number of life and safety projects. What is the nature of these life and safety projects, and how can they be important to infection control in state homes?
Thank you for your question. Some of the life safety projects are redesigning or building new homes. Some of our colleagues are going to the small house model, which results in private rooms and private bathrooms, which have been a significant deterrent in helping the spread of COVID-19. Others are looking at situations for security and to limit visitation of unnecessary visitors into the building. It varies from home to home.
Well, thank you. Thank you. I'm over time. I yield back. Thank you.
Thank you, Chairman Takano. Dr. Rowe, you're now recognized for 5 minutes.
Thank you very much. And just for the record, I want to say that I never thought in 12 years of being in Congress that Plaquenil would become a political football. It's been out for 64 years. It's a safe drug. It's been used for systemic lupus erythematosus. It's been used for rheumatoid arthritis, for malaria prevention. So I just want to get that said. I've used it, seen it used hundreds of times in my practice. I'm going to step back. The chairman and I, a couple of weeks ago, met or spoke with Dr. Stone and Director Verma about a problem that I think is that we're missing. We're talking about one specific part, our state homes and our CLCs. This is a much larger problem. We have a 0.6% of the population live in assisted living or nursing homes in the United States, and 40% of all the deaths looked like occurred in those facilities. And I talked to the nursing home people and to Dr. Stone and others, and basically what they told me was this, that they needed adequate PPEs, they needed point-of-care testing. That is absolutely critical for it, Dr. Boyd, what you just said, to test the folks coming in to be sure that they're not a vector for the disease, and then adequate training, and then funding for those three things I mentioned above. I guess one of the questions I have with the state, and I've been a huge supporter of the state homes. I've been in many of them across the country, and they do a phenomenal job. It sounds like the one in Massachusetts had some issues because it wasn't inspected by CMS or by the VA. I'm not sure why that is, but it was not. And I guess it was about 3 years ago when we cleared the deck of all the backlog state nursing homes, state facilities, I should say. And it looks like we've got $19.7 billion that we put in the CARES package. And we've only used about $2.5 billion of that money. It looks to me like that we could address some of those needs of the state veterans' homes with the CARES Act money if we just simply directed it that way. If we did that, how would you want us to direct that money? Well, if you had the facilities, and as you represent the nursing, the state veterans' homes, what would you recommend we do? Because the funds are there right now.
Thank you for that question. Adequate PPE would be my first request, speaking for myself and not having had direct contact with my colleagues, but we have shared emails back and forth. Hey, I found a vendor who has masks today. I found hand sanitizer. So knowing that we had adequate PPE, especially as we talk about the potential of a second wave aggravated by the pending flu season. And then definitely for construction, we have homes. My facility is a 140,000 square foot facility, one level, mostly private or semi-private rooms. Having private rooms and that ability to isolate and the negative pressure will go a long way in helping all of us across all of our homes.
Well, do you have some idea about what the extent of that is across the 150 or so state veterans homes? I know some are brand new, some are being constructed right now as we speak with the money that we provided about 3 years ago or being approved. Because if we can get our hands around that, the money may be there right now to do those very things. And again, we need to focus where the problem is.
I would definitely like to go back and poll my colleagues and provide something for the record so I can give you accurate information.
I think the sooner we can get that, the better, because maybe we can facilitate some of those funds. A very simple thing, Dr. Boyd, and I think the VA will do this. And by the way, I want to give the VA a shout out for providing state veterans homes with the help. To me, the inspections, we have the Joint Commission in hospitals, that should just be standardized, and there should be a standard assessment that a state veterans home goes through, just like I'm sure the CLC does. But the National Association of State Veterans Homes claims that they have repeatedly asked the VA to include state veterans homes on VA's Access to Care website, like the GAO recommended last year, so that veterans can compare the quality between a state home and nursing homes. Why the VA not want to do that? That seems pretty simple to me.
We absolutely do want to do that. About 30%, as you mentioned, of our state veterans home, we do not have the data currently that figures into that equation to make it a comparison on the nursing home compare site. And we are working actively now. We initially had given a site to resolve, a time to resolve this as of July of 2022. That's going to be significantly less. We're working with GAO on that, and obviously with our data analytics folks.
So it's going to happen then.
It will happen, yes, sir.
One last thing, because my time is about up. To me, it's absolutely critical, and all the nursing homes across the country, 15,600 of them, are going to be sent point-of-care testing. You have to be able to do that in a state nursing home, any nursing home, to know if your employees are coming in, your clinical care people are coming in with the virus. And you've also got to be able to do that quickly. So is that available at state veterans homes now?
Currently, it is not available at state nursing homes. Those of us who are CMS will be receiving at some point in time a point-of-care testing device from CMS. But right now it is not. And we are definitely concerned about the lag in testing. I can test a staff member now and not know for several days that they're positive, asymptomatically positive, and they're working.
My time's expired, but you got to have point-of-care testing done right then. I yield back.
Thank you, Dr. Dunn. And I now call on Mr. Lamb for 5 minutes.
I would be Dr. Rowe, but that's okay. I like to associate myself with Dr. Dunn.
Thank you, Madam Chair.
Too many doctors on this committee. No, all good, all good.
Dr. Boyd, am I correct that the VA carried out a FEMA-directed fourth mission engagement at Southeastern Veterans Center in Pennsylvania from April 24th to July 11th? Does that sound familiar? That's the home in Chester County that had a lot of fatalities from COVID-19.
Would that be the same as the Spring City?
I know its official name is Southeastern Veterans Center.
I think it's the
dates
same.
I have are April 24th to July 11th.
That sounds about right, yes, sir.
And at the time that began, there were already 42 of our veterans at that home who had died due to COVID-19. However, it's been reported to me that during that FEMA-assigned fourth mission engagement that you did at Southeastern's Veterans Center, there was no testing support, meaning VA was not providing testing at that home. Are you aware of that?
I was actually told, contrary to that testing was provided, and when I spoke with the network director for that area, but I could surely get back to you on that.
Okay, yeah, we'll have to track that down because we were told that VA did provide testing support in 24 other states and in the District of Columbia, but did not provide it in Pennsylvania. Okay. And I wanted to know why that was. So if you could follow up on that and determine whether Pennsylvania received it, and if not, why not? I mean, it could be that our state didn't request it of you or that you didn't have testing available. Please get back to us on that. But going further into the issue of testing, which Dr. Rowe was just raising, I want to make sure I understand the current situation. So as of today, does VA have the resources to go into any state veterans home that needs help and test every resident?
Today, currently, and that would be about a 23,000, a guess, 23,000 residents, and I'm not sure the number of staff. We do not currently, but we are working on trying to to facilitate that as an approach for American healthcare.
Does VA have the ability today to test any one of its patients or employees within the actual VA health system?
Absolutely.
It does. It could test every single one of them today if they had to.
Every single one on the same day, tests could be drawn, but they would not be resulted. We have to prioritize currently with regards to symptomatic, high risk, high exposure right now. And then any routine, I'm just curious if I've ever had it test, gets drawn and sent out.
And in fact, we're not doing daily tests of employees, correct?
To my knowledge, but it's a large healthcare system. We do routine testing of the highly vulnerable areas, i.e. spinal cord injury, the CLC, the nursing homes, and obviously preoperatively as well.
I think what's difficult for my constituents at least to understand is that we have a construction site in our district. It's run by the Shell Corporation. It's one of the larger construction sites in the country. They set up their own testing lab, and they can test any employee anytime they want and have results within 3 hours, not even a day. You know, and if you're an average person in Western Pennsylvania, you're still waiting 6 or 7 days in most cases to get test results back. So I look at the VA and say, you're the largest health system in the country, you know, 9 million patients or whatever it is, awash in federal money. We've given lots of money through the CARES Act and through these other bills. Why is it that 5 months into this pandemic, we still are not at a place where any veteran or even anyone that works in the VA can get a test when they need one or if they want one? Why 5 months? I would have understood your answer in February or March, but why at the end of July is that still the case? Have we not given you enough money? Have we not given you the right resources? What's the reason?
It's a very complex answer, and I'll be glad to get back to you on that. But in a nutshell, there are several, not barriers, if you will, but rate limiting steps. One, first of all, would be the machines. We have machines throughout the entire country, but then we're dependent on the reagents. We're dependent on the consumables, and those have to be manufactured by large companies that in fact have just a certain amount that they can send out as well. So we are grabbing everything that we can through multiple resources for this. I think that
Do you think it would help if the production and distribution of those reagents was managed at a higher level than the VA, like at the highest levels of our national government?
What I'm talking about is actually coming from companies. So this is much higher than the VA. This is,
Right.
out there in industry. That's what I'm talking about.
Thank you. Madam Chair, I yield back.
Thank you, Mr. Lamb. And now I call on Mr. Mercer for 5 minutes.
Thank you, Madam Chair. Thank you all very much. Thank you for your service. So the VA in my district, and I have one in my district and another Lebanon VA, the Wilkes-Barre VA, where we have many veterans that within my district go to the Wilkes-Barre VA as well. But they, in fact, acted very quickly and learned fast. They abided by CDC guidelines, which often changed relatively quickly because this thing moved quickly and everybody was learning. So they appreciated that. They kept their eye on that and they moved quickly. Early on, they restricted visitation, made sure that the staff wore PPEs, sanitized, and switched to 93% telehealth quickly as well. They also had adequate testing of patients and staff. Initially, of course, just based upon symptoms, but they covered staff very, very quickly and all. Throughout the Commonwealth of Pennsylvania, we have a population of 12.7 million. State cases are 110,000. Just going to give you a little data here. The fatalities in Pennsylvania was 7,100, with an average age of 83. The nursing homes population in Pennsylvania, all nursing homes, was 80,000 approximately, 90% of capacity. The fatalities were 4,900, 69%. So inside of a population of 80,000, clearly the most vulnerable, we all knew that early on, there were 4,900 within a population of 80,000, and outside, throughout the rest of the state, basically 12.7 million people, there were 2,200 fatalities. So significant disparity to say the very least. Now, when you look at and clear data-driven knowledge as to where the problems were, now, and where the most vulnerable were. So let's just use the Lebanon VA and to show their data certainly constitutes how quickly they moved. The patient population is 47,000. They had 0 fatalities out of that population. The nursing homes, however, they did have 5 fatalities. And the VA state nursing homes throughout Pennsylvania, I can't get the data on. So I'm wondering if maybe we can, I can access that in a way. So the CDC guidelines for quarantine were followed. Testing was positive. They kept the older population in particular, everyone for that matter, not just the older population, they kept them isolated. They kept them isolated primarily from the more vulnerable older population. They did not follow our State Department of Health guidelines to return COVID patients back into nursing homes, back into the most vulnerable of the population. So to me, and then you look at what happened in Spring City, and so I'm gonna lead to that and get the question. To me, yes, this VA responded extremely well. Best practices were followed. Whether or not the VA should have more oversight of the state nursing homes, the VA state nursing homes, you know, I don't know. What I do know is that best practices and the CDC guidelines worked. So, and they didn't work, for instance, in Spring City. So could you answer me what truly went wrong? Why is there such a diversity in following of the basic, the ground level guidelines? And then of course, just like we try to do, we try not to have all the answers here in Washington. What we try to do is provide the best basis and improve from there. Can you explain why that wouldn't have been maintained just in 2 hospitals, by the way, VA facilities that are no more than 60, 70 miles apart? Please.
Each individual home is responsible for their infection control. Not having personal knowledge of their daily operations, I couldn't speak to specifically why there would be a difference. Hot spots, areas of the country that have had more significant cases of COVID, obviously we've seen higher cases. In Vermont, we've had very low cases of COVID in the community. I have not had a COVID case except for 1 employee, but.
Okay. I am over my time, unfortunately. If there's any way I could get that information, perhaps after or in writing or an email, I would greatly appreciate it. Your response, Dr. Boyd. But I am over my time. Madam Chair, I yield back.
Thank you, Mr. Mercer. And I now call on Mr. Kennedy for 5 minutes of questioning. Mr. Kennedy, thanks for joining us.
Thank you, and apologies for the setting, but a little bit bouncing around a little bit at the moment. Mr. Barbani, you've spoken at length and in great depth about the flaws in a system and your frustration about addressing them. I wanted to start with something a little bit different and ask you, sir, just to share a story about one of the residents that you knew that we lost during the outbreak in Massachusetts.
On the February 29th, I was invited to the home to attend the 102nd birthday party for Tony King. Tony King is quite a notoriety. In 1934, he was a captain of an American Legion baseball team that went to Gastonia, North Carolina for a regional championship. Their star pitcher was Bunny Talaferro, an African American. The team arrived in North Carolina. Bunny wasn't allowed in hotels, couldn't play in the game. Tony's the last survivor of the team, and he was the team captain. And he said, "It's not right." The team packed up, went home, didn't play in the tournament. He had no children, but his niece Anne is on our coalition. She's an infection control nurse. She dealt with this tragedy, with misinformation, with getting conflicting information. So it was just horrific. We sat with 4 family members a week ago and just listened to truly gut-wrenching stories. So yeah, these are true American heroes. People who freed concentration camps, were at D-Day, and to see them die and to see them go in that manner. And the families are so impacted because of they weren't able to be with them at the time of the death. There was no wakes, and they just went to a funeral. One person talked that the last time the veteran's wife saw him was when they unzipped the body bag and saw his face with sauce.
Sir,
Horrific.
thank you for sharing that. Thank you for sharing his story. I had the incredible honor of visiting the soldier home right around Veterans Day back in November. And at that point, shaking hands with these heroes and hearing their stories and what they had done and what they're being with their families and the sacrifice and courage for our country. Sir, you spoke throughout your testimony about the failed patchwork approach of oversight to soldiers' homes. And based on what happened in Holyoke and suggestions from leaders like yourself, I drafted legislation to address many of those concerns, particularly as they related to infections. And you already mentioned one of the infectious disease experts that's on your panel. I wanted to run through a few of those policies in the minute and a half or so that I have left. But would you support strengthening state home administrator requirements so that the person responsible has medical care experience?
I don't see that it's an absolute necessity for the superintendent. I think the deputy could be at least one of the 2 within the home, should have that experience. But I think it's quite a restriction for the superintendent himself. And also, in reading the governor's proposal, that was going to be an at-will employee for the superintendent, and it would probably change with administration. So there'd be turnover and lack of continuity. So my feeling would be probably better to be the deputy and be free of that.
But somebody at the upper level that has actual professional expertise there.
Absolutely, absolutely.
And would you support strengthening the governing body so it's no longer just one person?
I don't understand the question. The governing body, in my mind, is the Board of Trustees, which are 7 members.
Okay. Would you support requiring all facilities to have an infection preventionist, an infectious disease expert on site?
Absolutely. And if I could, I know I'm your time, but I did pull up the actual survey to read the comments, and it did say that I think it may have been in the DOM, but the comment did say that the facility, did not have the program. I can pull up the exact quote, but there may be confusion between the DOM and the facility. Yes.
And last one here briefly. Long before the outbreak in Holyoke, you were raising concerns about systemically underfunded soldiers' homes. If you were to guess or take your best estimate, how much funding above current levels do you think it would require to properly fund our soldiers' homes?
In 2014, I put together a plan which addressed basically nursing staff, and that would have cost an additional $2.5 million to do the full thing right. But then there's additional staff beyond that, and that was in 2014. So it'd be a significant increase. Let me just, if I could, I pulled off information from the NASVA site, and it says Holyoke has 215 full-time employees and 148 part-time, with the 269 beds. Chelsea, 400 full-time employees and 40 with 189 beds. So absolutely disproportionate funding to, I figured out one time about $25,000 a bed at Chelsea more so than at Holyoke. So it's absolutely disproportionate. The other thing that's important is that 148 of the employees at Holyoke are part-time employees. And I have real concerns about part-time employees working at 2 facilities and being, as we talked, the vector of bringing things into the facility. And if they're going to call out, they're going to go to the place that isn't hot, so we lose that staff. So we really need to look at that staffing.
I appreciate it, sir. And Madam Chair, thank you for your flexibility with the time. I yield back.
Thank you.
Thank you, Mr. Kennedy. And I believe Mr. Gottheimer I recognize Mr. Gottheimer for 5 minutes of questioning.
Thank you, Chairwoman Brownlee and Committee Chairman Cano and Ranking Member Rowe for calling this hearing on this unacceptable crisis in our state veterans' homes. and for inviting me to participate today. I'll never forget the first phone call we received about the state-run veterans home in Paramus in the 5th Congressional District I represent. It was from a panicked loved one of a facility resident, his brother-in-law, a Korean War veteran. He just learned secondhand that there was a massive outbreak of the coronavirus in the facility. His family hadn't even heard a peep from the facility's administrators. Unfortunately, he wasn't alone. Overnight, the story broke that 37 people had died in the facility in just 2 weeks. Immediately, Congressman Pascrell and I wrote to the Secretary of the VA requesting immediate assistance, strike teams of nurses and doctors, as well as PPE to protect staff and residents. Eventually, at our urging, 56 VA personnel and 65 New Jersey National Guard members were sent to the home, helping to stem the tide of the outbreak. We even sent top doctors and infectious disease experts from North New Jersey's world-class hospitals to help advise and monitor the facility. At one point, up to 98% of residents had either tested positive for COVID-19 or awaiting test results or already hospitalized. In total, more than 80 veteran residents in Paramus who served our country with honor tragically died there from the virus. In early April, Congressman Pascrell and I wrote to the VA's Inspector General requesting an immediate federal investigation to find out exactly what went wrong, how this could have been avoided, and why families were not notified sooner. I would like to respectfully request unanimous consent to enter the correspondence into the committee record. The IG replied, the NJDMVA has principal oversight of these facilities, and the facilities are licensed by the New Jersey Department of Health. Those authorities would be the appropriate officers to make the information that you requested available concerning the care of veterans in those facilities. Moreover, with respect to your questions about VA's oversight roles and actions, the VA would be in a better position to provide responses to those questions. Given VA's relatively limited role with respect to the state veterans nursing homes, we have not opened a review of this matter. 80 people died, 80 heroes, and a refusal to act. That's simply unacceptable. So the question is that I have to this committee and to those who are testifying, I think we all have a right to ask who's in charge. It's also why I've introduced bipartisan legislation, the Nursing Home Pandemic Protection Act of 2020, to ensure much stronger and stricter federal oversight of these veterans' homes and other long-term care facilities, and helped introduce legislation, the SOS Act, to create rapid response strike teams of clinical and non-clinical staff to provide immediate support. As you know, outbreaks of the coronavirus that could have been avoided just didn't happen at the New Jersey home in Paramus and Menlo Park, but also the Soldiers Home in Holyoke, Massachusetts, the Charlotte Hall Veterans Home in Maryland, the Southeast Louisiana Veterans Home, the Veterans Community Living Center at Fitzsimmons in Aurora, Colorado, and many others. This is a national problem. What happened at these homes? What changes must be made to ensure this never happens again? What do we owe the families of the residents and staff we have lost to the virus? These are the answers we seek with this hearing. I look forward to hearing from our witnesses. Mr. Barabani, the Paramus, Menlo Park, and Vinland homes owned and managed and operated by New Jersey Department of Military and Veterans Affairs. The VA provides some funding through the per diem program and monitors care received at state veterans homes nationally through contracts for survey reports regarding the home's environment and care facility delivery. The homes are also periodically monitored by CMS. What do you make of this arrangement? In your opinion, what form of oversight is best to make sure that these kind of crises never happen?
I understand there's some redundancy between the VA survey and the CMS survey, but I can best talk to my own experience at Holyoke, where it was a state facility, unlicensed. Our only survey was the VA survey, and we did have the Joint Commission every 3 years come and do a survey as well. Our recommendation as a coalition is that that home be put under the Department of Public Health and be held to the scrutiny of our own state, as well as the VA survey.
Thank you. Ms. Jackson, why were state veterans' homes so poorly prepared across the board in terms of PPE and containment? And would you agree that the clear failures to contain the virus in the state veterans' home, like the one in Paramus, demand a comprehensive federal level investigation by the VA Inspector General or GAO?
Thank you for your question. PPE was difficult to obtain on a national level, so state veterans homes were in the same boat as everybody else, but we did work together as an organization, as I stated earlier, identifying vendors that we would share with each other. I found someone who has masks today. New York may have somebody who has gloves to help us work together to give the equipment we needed. any death of any veteran is a tragedy, and we all need to learn from this pandemic so we can share best practices. So any investigation would benefit all of us.
Thank you so much, and I yield back. Thank you so much for having me.
Thank you, Mr. Gottheimer, and thanks for joining us today. It's nice to have your comments since you are so close to some of these issues that we're discussing today. I now call on Ms. Houlihan for 5 minutes. Welcome.
Thank you. Thank you, Chairwoman Brownlee and Ranking Member Dunn, for convening this very important hearing today. And thank you especially to my colleague, Representative Lamb, for allowing my participation in facilitating that, even though I'm not a member of this committee. The COVID pandemic has certainly hit older Americans particularly hard, and long-term care facilities and nursing homes across the country have experienced tragic outbreaks that have sickened and killed many seniors. The Southeastern Veterans Center in my district, Spring City, Pennsylvania, is a state veterans home in my community that I've had the opportunity to visit several times during my just a year and a half in Congress. It has nearly 300 beds and 430 staff, and it has served hundreds of veterans and their spouses from our region. The COVID-19 outbreak at Southeastern Veterans Center has broken the hearts of many in and around my community, and much of the story has already been publicly reported, so I won't go into very much detail, except that we certainly owe it to our veterans, including those who still live in that facility, to do everything in our power to prevent this from happening again. My questions are to Dr. Boyd. The VA purchased hydroxychloroquine for use in VA medical facilities. Did the VA provide any guidance to state veterans' homes about that procurement or about the use of hydroxychloroquine? You mentioned earlier in your testimony that you were in constant contact with the state-owned VAs.
Thank you for that. And to my knowledge, there was no specific guidance with regards to prescribing of the medication, but just to be clear, hydroxychloroquine has been around for many, many years, and for any prescriber can be an off-label prescription.
Again, Dr. Boyd, did anyone at the VHA receive inquiries from leadership or staff at the state veterans' homes, including at my facility, regarding the VA's choice to use hydroxychloroquine on VA patients, or regarding the safe use of this drug?
For any, I would have to query the system to see if we had any communications or contacts. I wouldn't be able to comment on any.
I would love it if you could do that. I know that I personally, spoke with, as this was ongoing in my community, with some of the folks in leadership at the state-run VA facilities and asked them if they had had any contact with you, but I'd love to know if nationwide anybody did. This is to anybody and to everybody. Does the VA plan to issue guidance otherwise work with the state veterans' homes as any new diagnostics or any new, hopefully, treatment or vaccine is available? I guess what I'm getting at is it seems as though the VA was more responsible and more responsive than many of our state-run facilities. There seems to have been core competency or best practices that possibly could have been shared with the state-run veterans groups like mine in Spring City, and I'd sure like to see lessons learned in real time rather than post-pandemic and post-autopsy. So I'd love anybody to comment on that.
Thank you for your question. From the start of the pandemic, NASVA has worked to share best practices through state veterans homes. Our website has a resource page. Shortly after the pandemic, we had several of our state veterans homes who had positive cases get together with NASDVA and did a town hall. What are we seeing? What are we learning? VA has done all kinds of training with us, made resources available. So we have that open dialogue, and it's been worked very well for most of us.
Ma'am.
Thank you. And I could just add as well, thinking back to late February and early March, it almost seems eons ago. But we worked 7 days a week in the trenches. We had staff working on this constantly. As someone mentioned earlier, CDC guidance and lessons learned from the professional societies and critical care were changing all the time. And so we were very eager to reach out to our state veterans home folks to share with them what we had. We had training modules that were externally public facing as well. Anything and everything that we learned, good and bad, we wanted them to know.
And my last question with my last 49 seconds is, I believe that there's a possibility that we might have a vaccine at some point in time. I sure hope that there might be one. I'd love to understand your commitment to making sure that that vaccine has gone through all of the proper channels for approval before it is given to any of our veterans. Specifically, I'd like your commitment that it needs to pass phase 3 and be approved by the FDA before we give it to any of our veterans.
So you bring up an exciting part of where we are now. I think that we all wait very, anxiously for vaccine approvals, going through all of the steps that you're talking about. This is a rapidly evolving, very dynamic part of our research world. Very committed, very arm in arm with all the other research folks out in American healthcare as well. Our veterans are always the first to raise their hands, aren't they? They want to be involved in any sort of research or improvements in healthcare. So I will take that message back to our research folks. We're in constant communication, but we do definitely want to do the right thing by our veterans and by the American people. So thank you for that.
And I know I'm out of time, but I really would like to have a commitment that unless and until it has passed phase 3 and it has been approved in phase 3, that we are not giving this to our veterans. I'm not talking about people who are part of the testing of this. I'm talking about whether we are giving this vaccine to people in our veterans facilities that has not yet gone past phase 3.
Once the vaccines are approved through the normal channels, they will be available for giving to our veterans.
And I know I've run out of time. I appreciate the chairwoman's time, and I yield back, and thank you.
Thank you, Ms. Houlihan, and appreciate you again being here, as you are close to one of the facilities where it didn't go as well as it should have. So we appreciate it very, very much. I'm going to do a second round of questioning, and I will recognize myself for that. And so, Ms. Jackson, I wanted to ask you, we've talked a little bit today, and Ms. Houlihan, if you want to stay, you would be in line for additional questions if you wanted to. Okay, very good. Ms. Jackson, we've talked a lot, it's been brought up several times about the PPE issue at the state veteran homes, and you've talked about the creativity that homes utilize to bring PPE into their facilities. And in the CARES Act, Congress passed in late March, we authorized VA to provide PPE to state veteran homes. And so our staff here on the committee has been combing through a lot of documentation VA has provided to the committee to date. And our staff could only find evidence that VA has provided PPE to state veteran homes in 8 states. And in most instances, VA has not told the committee how many items of each type of PPE has been sent. So would you say that the Department of Veteran Affairs has become a significant source of PPE for state veteran homes since the CARES Act?
From my personal experience, we were reached out, our VMAC reached out to us and asked if we needed PPE, and we did not. To give you a credible answer, I'd have to poll my colleagues to get back to you. But I know some have leaned very heavily on the VA and have been responsive in getting PPE that they needed.
Do you know if your colleagues know they are able to pick up the phone and ask the VA?
They should know that we have shared that.
Everyone knows that?
Yes.
Across the country?
Yes.
Okay. Dr. Boyd, so can you talk a little bit about what's kept VA from supplying state veteran homes with more PPE?
I will answer this briefly. We have multiple ways with which to do this. One way is, and I'll ask Mr. Lilly if you will so indulge us from the field how that works, but what we have on record through our mission assignments, our codified mission assignments, we have supported the state veterans home in more than 440,000 pieces of PPE. So,
and in terms of what the committee had researched, that was in 8 states only?
I'd have to go back to look about the states, but I can get that for you.
Okay. So I think it's clear that there is still a need for PPE, and it would be nice if the state veteran homes could indeed pick up the phone and ask for PPE and receive PPE. And I understand, and I know Mr. Lamb was talking about this as well with regards to testing, is that, early on, understand the issue with PPE and the struggles of getting adequate supplies. But it's my understanding now that that the VA is sending out data that's saying that you have quite a stockpile now of PPE and in good shape. So I'm hoping that we can improve upon that to make sure that our state veteran homes do have the adequate supplies.
If I could just have Dr. Taylor mention something as well, Madam Chair.
I just wanted to say that the PPE issue was addressed also in our town hall meetings that we had on the 17th of March and then again in April with our state veterans homes. So we want to make sure that, we provided the PPE to those homes where it was needed, but we did have that dialogue with them fairly early on. Thank you.
Thank you. Mr. Barabani, I wanted to ask you that now that we're really starting to see sort of the dire impact of this pandemic, particularly on state budgets across the country, what are your concerns for state homes who are really, I think, already under-resourced, and now states facing dire circumstances relative to their own budgets?
I personally have, or we, the coalition, have got serious concerns about the situation at Holyoke, in that we've gone through a phase and we lost the 76 veterans, and then they all came back and the home was clean. They now have another positive case. My guess is it may have come in because no visitors have been into the facility. I am not convinced that they are prepared to deal with a second wave. They better call the National Guard now and put them on orders, because if it happens, I don't see how Holyoke will be prepared, and I really can't answer, what the state budget capability would be, what funds they may be able to tap into. But the problem at Holyoke becomes, who wants to work there now? You can't even hire people. It's going to be a challenge to get people to go and commit to working at that facility. So that's going to be a long-term rebuilding of that facility.
Did the state of Massachusetts augment revenues for Holyoke ever? The state, did they provide any additional resources to the facility?
What I was told, or what I've read in the paper, is that there was $6 million that was committed to some renovations of some of the rooms, taking off old wallpaper and taking out wooden cabinets and putting in things that are less infection, prone to spread. So there has been some renovations to the facility, but we don't see that as a real long-term solution.
So, Ms. Jackson, your perspective on state budgets?
Each home is operated differently. For example, in the state of Vermont, I receive general fund money every year to help with my budget. One of the things, as I pointed out in my testimony, is that our censuses have dropped dramatically. So prior to COVID, my census was $125 per day. Now it is $107. So the VA support of my home has dropped based on the per diem, because my census has gone down, but my costs have gone up 30%. So I will be asking for the state of Vermont to fill in that budget. I've heard from other homes, just from the beginning of the pandemic through yesterday, they've lost $1.6 million. So they will be leaning on their state governments as well to ask to fill in those.
I understand in your testimony too, at least the way I read it, that you were recommending a different funding formula coming from the VA to the state nursing homes, modeled after some other funding source. I can't remember now which one it was, but that you were requesting that. And, I think that's something that the VA should take a hard look at. Chairman Takano, do you have questions?
I do.
Oh, Dr. Dunn, I apologize. Dr. Dunn, I'm sorry, because I just assumed that you didn't want to ask a question because you were under your time the last time around. I deeply apologize. Dr. Dunn.
Thank you, Madam Chair. I'm so taciturn over here that I think, sometimes I just don't get your attention. Actually, you're quite correct. I don't have a question, but I do have a reminder. I want to ask Dr. Taylor or Dr. Boyd, who's ever in charge of these things, to please get me that list of just suggested corrective actions for the nursing homes, in a format that we doctors would understand each other. And I only remind you because sometimes we on these committees think that we don't always get the things that we ask for when we're in the committee meeting. But I know you're going to follow through, so thank you very much for all your efforts.
We have it on our notes, sir.
Thank you.
Madam Chair, if I could just add one thing, he made me think about something. I have a message for you as well. Your long-awaited COVID-19 response plan and the high consequence infection plans were finalized yesterday and all through concurrence. We'll get copies to you as soon as we make the final formatting. And in that, speaking to Ranking Member Dunn's comments, significant number of lessons learned, and we're adding those real time. So it's not just the first plan, it will be full of what we're learned and what we've learned and put in there. So, and it will be added on. This is a dynamic process. So I forgot
When
to let
is
you
it
know.
going to get distributed nationwide?
We're doing calls to get the information out quickly now to the field because that's where that's where the patients are and that's where the implementations are. But as far as we would love to get it to you. Probably won't be the end of this week, but surely by next week. That is what I'm aiming for. But I wanted to let you know we finally got it through.
Thank you, Dr. Boyd.
You're welcome.
Chairman Takano.
Thank you, Madam Chair. Ms. Jackson, you said because you are also a CMS, you also accept CMS patients, that you're expecting to get rapid testing machines. Have you been sent memoranda or notification from Ms. Verma's office that is going to happen?
Yes, I believe it was last week we had a CMS town hall where they explained they would be sending out to CMS certified homes, those in the hotspot areas or those with the highest level of COVID
And
first.
do you know what machines you're receiving?
I do have those notes, but I do not have them with me.
Is the ID Now one of the tests that you remember, one of the testing machines?
It does not sound like it was. That name doesn't sound familiar. One started with a D, one started
Well,
with
it's the ID Now, it's a rapid test.
Right.
And it's made by the company out in the mid, I'm blanking on their name right now, but.
They gave us the company name, they didn't say specifically. They were sending us that as well as the initial 400 test meat kits to do 400 tests.
Okay. What I'd heard from Seema Verma is she's intending to send out the 2 tests, and she named one of them, which was the ID Now test. Dr. Boyd, even though you don't have the statistics from the CLCs, my understanding is that the CLCs were extensively tested, both the employees and the residents. I don't believe they utilize the ID Now test or rapid testing to test those residents because of the accuracy of that test. Am I correct?
You're correct. At the time, the accuracy, the false negatives were very concerning.
My understanding is that the false negatives are still a problem, that there's been no market improvement in the performance of that test or the administration of that test.
To my knowledge, there is still work being done on it. It's not something that we're using now.
Ms. Jackson, would it concern you to know that the VA does not use the test in their CLCs, but CMS is proposing to send possibly these tests out to people like you?
Personally, yes, it does concern me because what is most important is finding that asymptomatic individual so you have that information right in front of you. I do know, coming from Vermont, that our Commissioner of Health is not overly keen on that device, so I would be following his guidance as to whether or not we would be using the point of care testing in the Vermont State Veterans Home.
I know that it's the Abbott. It's the Abbott ID Now test.
Yes.
There's a second test. I don't know the accuracy of it. The VA folks were not able to tell me what that second test was. This is CMS. I can tell you that I've questioned the VA, informally, and they do not use the Abbott Rapid Now test for infection control. It makes no sense to have a test with at least a 25 I've heard up to 50% accuracy errors or accuracy problem for infection control, when you actually need to turn around, you need to turn it around quickly, but also get very accurate results. And managing infections in environments such as veterans nursing homes, this is, I find it absurd that this is CMS's solution. And I just wanted to make sure I get that on record, that I don't believe VA uses the IDNO test in its medical centers. Widely, I think maybe one place they're still trying to work it out. Dr. Boyd, am I correct in that?
I can get you the exact specifics on that, but we were very concerned about the early results on that, the performance of that test, and so we do have other options that we use more routinely.
Okay, this is very frustrating to me, to be like a Cassandra, to know something, and to know that a disaster is about ready to happen. And to have that knowledge, and many of you have this knowledge, many of Dr. Jackson and others in the audience had this knowledge, and be unable to use that knowledge to have an impact on how we can change things. And I'm very concerned that CMS is distributing this ID Now tests to hotspots around the country who are looking to control infection in places of congregate living areas and not be able to get accurate readings and have a rapid test that doesn't really, that you could miss significant numbers of asymptomatic positive people. So I had other questions, but that I thought that was the most important thing to kind of sound the alarm on right now. I yield back, Madam Chair.
Yeah, thank you for that, Chairman Takano. I think, you're making an extremely good point, and I think the reason why nursing homes were so severely impacted is because of testing and the lack of testing.
Well, when our CLCs were very good at it, we had the resources, and the lesson learned from the VA success is to prioritize this equipment and testing to our nursing homes and our state veterans homes. But here we have CMS pushing out a test machine that is highly faulty, and we still haven't figured it out how to use it at the VA, and they don't use it at the VA. And so that's what I felt was so important about this hearing, Ms. Brownlee, and why I'm so glad you held it. This is a key point that I wanted to get out to the public.
I would think that every VA medical center would have laboratories to get a quick response on testing. Is that not true?
I can get you the exact number, but most of our centers, we actually cross-level another test that you may be thinking about, the Cepheids. They are a quicker turnaround that we use for, not really pointing, but it's a much quicker test that we can have results very quickly.
That's a 45-minute test. The Cepheid test we have, I was not able to verify with Administrator Verma about whether or not that was another test, but that is a highly accurate test. It's 45, it's not a 15-minute test, but it's highly accurate. I don't understand why we haven't ramped up the capacity to build more of those. They're domestically produced, Chairwoman Brownlee. I don't understand why we haven't prioritized this sort of test so that people like Ms. Jackson can manage their facilities properly.
Well, I think we put lots of money in the HEROES Act for testing, so we're trying to push out the resources to make that happen.
Yep.
So, Ms. Houlihan, you're recognized for a second round of questions.
Thank you, Madam Chairwoman. I understand that the VA has a mechanism currently for annual inspections of state-run facilities. Is that correct?
Yes, that's correct.
And would it make sense, and anybody can answer this, perhaps to have a mechanism for emergency inspections, for on-the-spot inspections in the event of something like a public health emergency like we're experiencing now?
Yes, in our current directive, we have the ability, if we have some concerns, to connect with our state veterans home partners and visit.
But is it an ability to do an unannounced inspection, or do you have the ability to contact them and visit?
Yeah, we have the ability to do unannounced.
But Ms. Houlihan, I will add that inspections were, during the COVID crisis, the inspections that a contractor does for the VA was ceased. So at the time when we're having, a pandemic, staring at us, we're not sending folks in.
Excellent. That's a really nice clarification. Thank you. My last question is for Ms. Silas. And has the GAO made any recommendations to improve the VA's oversight of state veterans' homes that you believe, if implemented, would have helped stop the spread of COVID-19 and would have improved the crisis response in the event in the future of a future or similar outbreak?
In our 2019 report, we identified some areas where VA could improve their inspections. I can't speak to whether or not they would have helped prevent COVID-19 spread in the VA nursing homes. But we do believe that if VA implements our recommendations, especially the one that continues to remain open about citing all failures to meet quality standards, that will be helpful. I know in some other work that we have done, looking at community nursing homes, infection control deficiencies were the highest number of types of deficiencies that they had. And a lot of those deficiencies were cited as low-level deficiencies. So simple thing as, washing hands, which would seem to have a huge impact. We now know, based on our experience with COVID-19, that diligently washing your hands is very important to preventing the spread of COVID.
And thank you. And I guess my final question is more of a blue sky, spitball type of question for all of you all. I just came from Foreign Affairs, where we're going to be voting and passing through some legislation to make sure that this never happens again from a foreign affairs perspective, that we are able to be collaborating with other nations and with other organizations to develop future vaccines for things that might be future pandemics. If you could, summarize something that we could do if we had only known for the next inevitable pandemic that we will experience, whether it's another spike of COVID or something else. If you knew then what you know now, what would you do in the future to prevent this from happening in our VA facilities of all kinds?
From my personal perspective, it's looking at PPE. When you look at emergency preparedness in healthcare for years, it's been making sure you're prepared for your hurricanes, your tornadoes, having enough food to get you through a snowstorm if you live in Vermont. But that national supply of PPE and not having it made here in our country really hurt us. First, this is a personal opinion, in making sure healthcare had the PPE that they needed.
Thank you.
Yeah, I would add, in addition to PPE, which I think is a great response, we are used to, as was just stated, preparing for those regional emergencies. But preparing for a national emergency where our entire national system was impacted, not necessarily the same simultaneously, but certainly simultaneously, is something that we had not previously prepared for. So I think this has been quite a learning for us in terms of, preparing a little bit differently, not just for regional or isolated events, but very broad spectrum events.
And is that specific to supply chain management of things like PPE? Is it specific to like kind of bulk buying and, more collaboration across organizations or, okay.
Supply chain is certainly an element of that.
Okay. And I'm afraid I've run out of time, and so I yield back, and thank you.
Yes, thank you, Ms. Houlihan. And I would add to that list, too, that what we need in terms of preparing for the next pandemic is testing supplies, whether it's swabs, vials, the agents, everything that's needed, because that's been a sort of a similar disaster as PPE. So, well, I think we will conclude here. I have a couple of more questions, but I will submit them in writing. And I think, from this hearing, I think this has been a really important hearing, and I think that in terms of what VA has control of with regards to state nursing homes, they have control over their inspections and their oversight, and they have control over their resources to state veteran homes, albeit, you know, sometimes you have to come to Congress to get additional funds for that. But it is a role that the federal government plays in supporting state nursing homes. So I think I just, and I know that, Dr. Boyd, you said you are going to comply to the GAO recommendations. I think you agreed to all of the recommendations that they made. And I think that that is a good step in the right direction. I have to say, you know, I'll be watching that very, very carefully because I have heard VA say that they're going to agree to GAO recommendations and find that a year, 2 years, 3 years later, it hasn't happened. So I think this is an important process, not only for, you know, just ongoing assurances for quality care, but it is particularly important during a pandemic. And I think Ms. Houlihan made some good suggestions in terms of having some clear processes for a pandemic. It's interesting with VA's fourth mission in some sense. VA's never had to deal a fourth mission with 50 states across the country. It's always been isolated, you know, isolated into one particular area. And I think, you know, from my perspective, whether it's tightening up the fourth mission or tweaking it or formalizing a process more under the fourth mission or just formalizing a process in preparation for a pandemic, we really need to be ready, to stand ready to support our state veteran homes across the country. So I think that there is absolutely more that needs to be done. And at the end of the day, if the VA is not doing its job of inspections and oversight, we're going to lose more lives, because at the end of the day, when I asked the question at the beginning of this hearing, where does the buck stop? I understand your response, but the buck stops in terms of inspection and oversight with the VA. That's where, you know, from that responsibility, the buck stops with the VA, and we need to make sure that we're doing what we need to do, because those inspections and oversight is all about maintaining quality care. And just, you know, going into a facility and saying, well, we're gonna, you know, we're not gonna pay you anymore because you're not, you know, you're not adhering to what we expect is not a good, you know, it's a tool, but it's not a good solution, because we all have a moral obligation to make sure that our nation's veterans are taken care of. And I was talking to Mr. Neal before this hearing, and he said, you know, these homes are it's the last place that veterans really go to. So it is incumbent on us that we make these facilities the very best that they can be, because that's what our veterans absolutely deserve. So I think, Dr. Dunn, do you have any closing comments?
I will yield back to you, Madam Chair.
Okay. Then all members will have 5 legislative days to revise and extend their remarks and include extraneous materials. And I think I forgot actually to say without objection, unanimous consent on Mr. Gottheimer's request for a document to be entered. So we've taken care of that. So with that said, this hearing is now adjourned.